So what do you do when someone is in distress? How do you decode that distress or decipher what's going on, find those needs? Well, there's some basic things we already do. One thing is we think about, are people medically ill? Because we know that certain medical illnesses can cause distress. And we tend to call the doctor a lot. And when should you call the doctor to see somebody in distress? I think most of the time it's not medical illness. Sometimes it is. But if you see something that's really bizarre that you've never seen before, or if you see some sort of distress that's in conjunction with a physical symptom like a fever or abdominal pain, then that's obviously pointing to something you might want to check on. If there is a medical cause of distress, it's usually one of three things. Number one, a drug reaction. Number two, an infection. Number three, all the other medical stuff thrown into the third category, like congestive heart failure or abdominal blockage or whatever you can think of. But I want to make a comment about urinary tract infections because 20 years ago when I started working in nursing homes, we had to remind people that older people can get urinary tract infections and can become confused, and to think about the urine when someone becomes confused. So that's great. So in 20 years, we've taught people that lesson way, way too well. And now what happens is you walk down the hall, someone looks at you cross-eyed, you send off a urine and throw them on antibiotics. And 99% of the time, that's not what they need. I think what we've discovered is that we way overdiagnose and way overtreat bladder infections. As you age, as the prostate, the vaginal flora, the support structures for the bladder change, lots of things happen. And the kind of people that end up in care homes have a lot of changes to their pelvic organs. And as a result, when they check urine cultures on healthy people in care homes, what they find is that 50 to 70% of women have bacteria in their urine and white cells, and maybe 30 to 50% of men have it in their urine. So to send a urine culture off and get bacteria growing means nothing. It does not mean the person's infected. What you need is a hard symptom of an infection. You need a fever. You need abdominal pain. You need pain with urination or a change in continence different from what it usually is. If the person is just striking you when you're trying to bathe them, that doesn't mean they have a bladder infection. And so this is where we have to kind of get away from going too far down that road and really look beyond these medical things. I think it's only a minority of cases where distress is due to medical illness. The next thing we do is this sort of environmental audit, and we all do those things. Are you too hot or too cold? Are you understimulated, overstimulated? Do you have pain? That's a big thing. Don't forget, pain is not just a broken hip. Pain can be a very comfortable recliner chair, but if you're left there for 4 hours and can't shift your weight, all of a sudden it's uncomfortable. All of us subconsciously in the chairs, you're kind of doing this, you're kind of moving around, because we can make ourselves comfortable when we start to sit too long in one place. A person who's weak, who may have had a stroke, they can't do that. They can get uncomfortable very quickly if they can't shift position. So we look at that. We look at food, fluid, toilet needs, all those things, but we tend to stop there and then call for the pill. So the experiential model says, no, we have to go further. We have to look at the person's life history, their patterns, their hobbies, their likes, their dislikes. Look for meaning in the behavioral expressions. Do some role play to try to share the experience that they're having. And see if you can look at those domains of well-being and see what's missing. So look at the person's environment. Do they have autonomy? Do they have security? What can we supplement to help that person feel better in their environment?